for the day are Dr. Prashant Tibhare, who's a clinical scientist and associate professor in pathology and flow cytometry. So since it's a slide seminar, it's an interactive. Deepika?
Good evening, everyone. I'm Dr. Deepika Dalji from Mahatma Gandhi Medical College Hospital, Jaipur, second year resident.
Share again.
Is the screen visible?
Yes.
So, hello, good evening. Today we are going to see a few interesting cases and related to plasma cell neoplasm, and me and Dr. Neeraj will be conducting these cases. So I am going to take first case, then followed by Dr. Neeraj will take second case, then I think again third and fourth, fifth case. The next three cases I'll be taking, then sixth and seventh case Dr. Neeraj will take. So we will have alternate cases, and we have at this station interactive kind of station. So I hope the students who are participating will have some question answer kind of station, and as well as there will be the other attendees who have some questions can also put in the chat box the questions, and we'll try to answer those questions. Okay, so let's start. So this is an introductory slide, but what are the plasma cells? If you look at the plasma cell, it is a terminal stage of B cells. So I'm trying to get a pointer here. Yeah. So if you look at the B cell development, the B cells start maturing from the hematopoietic stem cells in the bone marrow. So bone marrow, we have immature B cells or B cell progenitor, which become mature and they come into the circulation in the peripheral blood. In peripheral blood, we have naive B cells which are not exposed to any antigen, and the B cells which do not have any interaction with the T cells or antigen-presenting cells. These type of cells. So those are nice cells. So the nice cells, when they come into the circulation, they either get exposed to the antigen in peripheral blood or in lymphoid tissue, secondary lymphoid tissue like lymph nodes or tonsil, liver, spleen, where they interact, where they enter into the lymphoid follicles and interact with the T cells, especially follicular helper T cells, which interact with the after the interaction, they become activated, undergo class switching and somatic hypermutation. And then some of the cells, based on the type of antigen interaction and the T cell communication, they secrete, they become plasma cells so that they will secrete antibody against particular antigen. Okay. Now, some of the cells will undergo, the activated cells undergo germinal center, and then they become memory B cells. These memory B cells are the B cells which has memory of that particular antigen, so that whenever we have introduction to that antigen, we have that antigen enters to our body, those B cells undergo proliferation and secretes the antibody against that antigen. And a part of these B cells again become long-lived plasma cells, and these plasma cells again come to the circulation, and from circulation they enter bone marrow again. Now bone marrow has a niche in such a way, a microenvironment which helps them to survive for a longer period, and that's why the plasma cells come back to the bone marrow. So the journey of B cells starts from the bone marrow as a progenitor, becomes mature B cells, interact, become wiser B cells, that is activated and memory B cells, and then become plasma cells, that is productive B cells, and they return back to the bone marrow. So this is just a figure which represent how the B cells mature and become plasma cells. So basically, and that's why, and this is very important because that's why they have similar characteristics like that of the B cells. Now, if you look at WHO 2022 plasma cell neoplasm, so this is beta version classification. A final WHO 2022 will come soon in June, I'm hoping. So if you look at this classification, it has classified these diseases, which is plasma cell neoplasm, as well as the diseases with paraproteinemia, into 4 main classes. The one is monoclonal gammopathy, then diseases with monoclonal immunoglobulin deposition, heavy chain disease, and plasma cell neoplasm. So earlier, if you look at the non-IgM or monoclonal gammopathy of IgM as or monoclonal with renal significance was classified under plasma cell neoplasm, but now there is different class of monoclonal gammopathies which is now described under that classification. So this is broad classification, but if you look at plasma cell neoplasm, it can be further divided into plasmacytoma, which again further divided into 2 types: solitary plasmacytoma of bone and extramedullary plasmacytoma. So plasmacytoma which occurs in connective tissue other than the bone. Okay. Then we have plasma cell myeloma or multiple myeloma, which can be again divided into 3 variants, clinical variants. One is smoldering myeloma, which is asymptomatic. Other one is non-secretory myeloma, a rare subtype, and the plasma cell leukemia, in which we have circulating abnormal plasma cells or tumor cells. So look at the plasma cell neoplasm associated with paraneoplastic syndrome. So we all know Poem syndrome, Then there is a Tempe syndrome, and there is ESOP syndrome. This ESOP syndrome is recently described in WHO. So now we'll start with the cases. Okay, so I'm sure our all participants are alert now. I may forget or mispronounce someone's name, so please apologize for that, because I'm not very good at keeping names in my mind. Anyway, so this is a case one. Let's see the presenting complaints. This 48-year male patient from the Kolkata, he presented with backache for last 6 months, had weakness, although there was no history of trauma or any fall, fracture. So on examination, clinician found that there was pallor, although there was no pedal edema. Chest was clear, abdomen was soft, so no hepatosplenomegaly, and the CBC was done in private laboratory, shows 6.8 gram per deciliter, which indicates anemia. So this is this patient referred to our hospital, that is Tata Memorial Center, and came. So this is CBC reports of this patient. So may I ask Jigisha that what do you think about this CBC report? Do you find any abnormality in this report? Jigisha, can you hear me? Zoya?
Yes, sir.
Yeah.
Sir, in this CBC report, there is low hemoglobin, RBC count and hematocrit is also low, and normocytic normochromic blood picture is there. So,
Right,
and,
right,
so,
right.
and
Okay. What else?
so there is RDW is high and platelet counts are low, sir.
Right, that is important finding. So patient has hemoglobin, low hemoglobin, that is our normocytic normochromic picture. Why do you say normochromic picture?
So because MCV is normal and MCH is also
Right, yeah. The MCV is normal, so which indicates, although there is RDW is slightly higher.
like
Anyway, but what is who is next? Neha. Neha is there?
No, sir. Neha is not there. Sir,
Okay, yeah, so Neha is not there. So Jigisha, if she is online, I would like to ask you what
Dr.
are the
Deepika.
so Dr. Deepika, what are the common causes of normocytic normochromic anemia?
So trauma,
Trauma, that is blood
any
loss. See, trauma, not simple
blood,
trauma, but blood loss.
yes, blood loss, bleeding disorders,
Bleeding disorders. Okay.
uh,
So see, we are normocytic normochromic. One is loss, when you lose RBCs. The other reason can be when you have less production. So
less production.
what are the causes of less production?
Uh, uh, when there is a bone marrow suppression, or there is a decreased production of the RBCs, or
Yes. So bone marrow suppression. When can you have bone marrow suppression? Since marrow element can be suppressed when. So if you have,
sorry, I can't.
so you said bone marrow suppression, isn't it?
Yes,
So
sir.
what are the causes of when do you get suppressed bone marrow?
Sir, in case of multiple myeloma, leukemias,
Right. So when you have marrow which infiltrate marrow infiltrative diseases, so like cancer. So either you have hematolymphoid malignancy, or there is metastasis from the solitary neoplasm, other solid malignancy, or less production due to aplastic anemia, hypoplastic anemia. These are the causes, as well as the chronic in the inflammatory conditions, and chronic infection can cause also. So these are the causes. So as she has already shown that there is anemia, clearly 7 is platelet count is also low, which indicates it's not just red cell disorder, but there is additional element because platelet count is also low. Okay, so these were the finding. Now there is a peripheral picture. Let me show the high power. Uh, so next, who is Deepika or Jigisha? Can you answer what is the finding in this slide?
So in this slide, we got the roulet formations.
Right. So any one of you, can you answer what is roulet formation and what is reason behind or pathogenesis of roulet formation?
Because of increase in M protein, RBCs coin like a stack of coin. They arrange like stack of coin.
So M protein or increased globulin level.
Immunoglobulin.
Immunoglobulin.
Increase in immunoglobulin level.
So normally RBC do not stack over each other. The reason is because they have negatively charged proteins in their cell membrane, and these immunoglobulins are positively charged proteins. So they bring these RBCs together, and that's why you get stock of RBC. So these are. So what are common causes? Anyone next person who is the Jigisha or Deepika, or I may ask Mulinga,
Mulinga.
Dr. Mulinga. What are the common causes of rouleau formation?
So I think one of them is what we have, what it has said on the because of the immunoglobulin, the M proteins. So the plasmacytomas which produce the plasma cell neoplasm which produce immunoglobulin is one of the causes of rouleau formation. Yes.
Right. Very right. Very good. So plasma cell neoplasm is the commonest cause. Also, you can have connective tissue disorders. So even some liver diseases also can cause where you can have increased globulin levels, and connective tissue disorders can also cause this type of rouleau formation. But plasma cell neoplasm is one of the commonest cause of the rouleau formation. So we have paper smear where because of rouleau formation, it is very difficult to appreciate the RBC morphology. But in CBC, we have seen there is anemia and low RBC count, but MCV is normal, so normals are now. So as we have expected that there can be some levels of deranged protein levels, so we have done biochemistry report. Here we have biochemistry report. So next person, let me ask Jigisha. What do you see any abnormality? This is our biochemistry report. Okay, if I don't know whether Jigisha can hear me. Let me ask Deepika.
Sir, in this biochemistry investigation, we found serum protein level raised, serum globulin is also raised, Ag ratio is reversal, and calcium is low, and serum creat is raised.
Right. So serum creatine is increased marginally. We have, but if you look at globulin levels, they are significantly raised, right? And albumin level, in fact, reduce. So this Ag ratio is reverse. That is true. So let's see. These are the abnormalities we can see. Even the urea is slightly higher on side, so which indicates that there probably some renal function has been compromised. Okay. Now this is so this is next because there was anemia. So we have done there's some other investigation which include serum vitamin B12, vitamin D, beta 2 microglobulin, and ferritin levels. Right. So anyone can anyone look at this report and say what are the abnormalities?
Serum vitamin B12 level is high. Serum
Right.
beta 2 macroglobulin level is high, and serum ferritin level is also high.
That is right. So serum vitamin B12. Now, usually in anemia, serum vitamin B12 is reduced. So anyone can anyone answer of you that what are the common conditions where you can have high levels of serum vitamin B12?
Macrocytic anemia.
High levels of the macrocytic anemia is because of low vitamin B12, isn't it?
Yes, sir.
In deficiency, here we have increased levels. Anyone? Anyway, so if you look at serum vitamin B12 high levels, it is usually increased in some myeloid neoplasms, especially with high counts, like CML. The commonest one is chronic myeloid leukemia, where we can get very high levels of WBC. Then some acute leukemia also, where we have high counts, can have high levels. Even some solid malignancies can have vitamin B12, high levels of vitamin B12. Okay. So let me tell you the reason is that because we have some protein called the heptocorrin, which binds with which binds, this protein binds with the cobalamin, that is vitamin B12. Okay, and it is secreted by mature and immature myeloid cells, and that's why if you have high levels of myeloid cells, there are high levels of these cells die, there is high levels of heptocorrin, which binds with the circulating serum vitamin B12. That's why usually high levels of serum vitamin B12. You can also have a serum vitamin in some liver injuries, liver diseases, because of the liver cell damage, and liver is a storage unit for the vitamin B12. So you can have transient high levels of vitamin B12. Okay. So that is there. So which indicates serum ferritin is slightly high. It just indicates some inflammatory reaction. Okay. So this is our tumor marker report, and the next report, because there was uh, high globulin levels. So we have done patients tumor marker studies, especially serum electrophoresis and immunofixation. Okay. So here you can see there is normally you show a small peak here, just a small peak here in this figure, but here you can see there is a large peak in gamma region. Okay, and if you look at the protein, and this is monoclonal band of immunoglobulin, and you can see this is in gamma region, so that is called as the immunoglobulin gamma, that is M band, and the concentration of M band was 4.2 gram. If you look at the other levels were within normal level, but IgG level was significantly increased. And if you look at the kappa and lambda, which is bound kappa and lambda, even kappa was increased, right? When they have done free light chain assay also, so the one light chain which are free, not bound to the heavy chains, if you look at kappa and lambda, the kappa is significantly increased, that is almost more than 1000 as compared to the lambda. And on immunofixation, so you can see this is immunofixation, and in immunofixation, this is the ladder where you can identify the proteins, and here you can see this is in gamma region. So IgG, which indicates IgG, and it is precipitated with kappa antibodies. You can see the kappa antibody. So this is so IgG kappa, and even the urine was done. So you can see the lambda was not detected in urine, but kappa light chain was detected in urine. Okay. So these kappa light chains which were detected in urine are called as Bain-Jones proteins. It is the older terminology, but now we call it as kappa light chains, but Bain-Jones proteins. So these are all abnormalities. We have increased gamma globulin levels with very high free kappa levels, and urine 24-hour urine also showed 12.2 gram of kappa light chain. Okay. Now, just an historical fact regarding Bain-Jones protein. So, if you look at Dr. Bain-Jones, who was a medical student in St. George Hospital in London, and then he was interested in chemistry, so he had done some fellowship in Germany. And when he was Germany, there was a patient to the physician, Dr. Thomas Watson, and he found a typical feature of urine. So it is very descriptive, very interesting what he has written later. The dear Dr. Jones, the tube contains urine of very high specific gravity. When boiled, it becomes slightly opaque. On addition to the nitric acid, it effervesces, then assumes a reddish hue and becomes quite clear. But as it cools, assumes again consistence and appearance which you see. Heat re-liquefies it. What is it? Okay, so then Ben Jones has, Dr. Henry Ben Jones, then the did studied, and then finally came up with this protein called as Ben Jones protein. But actually, he used the different terminology like hydroxy, some butoxin proteins, but albumin. But the actual term of Ben Jones protein was used by Dr. Fisher in 1980. And this is the old picture of St. George Hospital. Now it has been converted into hotel. So this is the interesting fact. Now coming to the patient again. So if you look at the patient, that patient had small lytic lesion. You can appreciate in the skull. You can see the lytic lesion here, lytic in here. Even in the humerus, you can see the lytic lesion. Although it's difficult to appreciate. Only I think radiologists can appreciate that. But here you can CT scan. You can see the properly. Okay, so there were lytic lesions, some sclerotic lesion too. So the patient's bone marrow was done. Okay, so let's see. Can I ask Dr. Malinga, what do you think? What is the cellularity of this bone marrow aspirate? Can you comment on the cellularity of this aspirate smear?
Yes, so this bone marrow aspirate shows hypercellularity. And
Right.
yes, if I can see clearly, I think there are cells which look like plasma cells more.
Very, very perfect. So as you can see, the particle they're completely replaced with the cells. There are hardly any fat cells for this age, which is clearly indicates hypercellular marrow. And as Dr. Malinga has rightly said, you can see many scattered and clusters of plasma cells. Here you can see the clusters. Here is the clusters. So there are a lot of plasma cells, and this is high power. You can see the high power. These plasma cells are there. There are a lot of the sheets and clusters of plasma cells there. So Deepika, do you see any typical feature in this plasma cell?
In this picture, plasma cells have eccentrically placed nucleus. Some of them are showing binucleated nucleus, and the nucleus is of eosinophilic in
Right.
nature, color.
Yeah, and it also shows nucleoli. See nucleoli. So normal plasma cell does not show nucleoli. Usually it is matured. It has some plasma blastic morphology, because you can see that clearly there are nucleoli in majority of plasma cells, right? And there are multinucleated plasma cells, as Deepika said very rightly. Okay, so usually, which indicates that neoplastic proliferation, because plasmablastic morphology is not seen in normal plasma cells. Although sometimes in reactive condition, you can see some binucleated plasma cells can be seen. So it is not a feature of neoplasm, but so many binucleated plasma cells, multinucleated plasma cells, then prominent nucleoli indicates or suggests neoplasm. Okay, then the patient's flow cytometric immunophenotyping was done. Anyone of you has, let me ask Zoya or Jigisha if they know what are the immunophitic markers which can be used to identify plasma marrow.
CD38, CD138,
CD138.
CD56. Also, they are
Right.
CD19 negative.
Right. So we have used the similar markers for immunophenotyping. We have used CD38 and CD138. You can see there is a population which is CD38 very strong, showing the strong means it is stronger than rest of the cells. So the cells which are close to zero are basically negative for this marker. And as you go away from this zero, it shows positive expression. So expression which is above, let's say 10 raised to power 1, is more suggestive of positives, and it as you go above and close to this upper margin, it becomes stronger and stronger. The expression becomes stronger. So you can see these are the rest of the cells, but we have these blue cells which shows CD138 expression as well as strong CD38 expression. And so yeah, Deepika, do you know which are the markers which we can use to differentiate between normal as well as abnormal plasma cells?
The CD27 and CD81,
Right.
CD28, and
Right.
CD56.
Yeah. So we use all these markers to identify, to differentiate between normal and abnormal plasma cells. So you can see we have used these markers. So normal plasma cells shows predominantly, not all, CD19 expression. So, but you can have a subset of normal plasma cell which can be CD19 negative. That's then CD56 expression is aberrant expression. CD27 weak expression. So there are few normal plasma cells in the background which are 19 positive. They are normal 27 and 81 positive. And the other population which is 56 positive, they are showing loss of CD27 because they are close to zero. You can see predominantly close to zero. Loss of CD81, as compared to these normal plasma cells. Also, there is aberrant expression of CD117 and aberrant expression of CD28. Okay, and we have done cytoplasmic, that is intracellular light chain evaluation, and you can see at this in this patient there is a lot of light chain expression, kappa light chain expression. So these all plasma cells showed clonality by showing the restriction. Almost 99% plasma cells shows kappa restriction, and very few plasma cells had lambda. Okay, so there are that which means there are abnormal clonal plasma cells. Abnormal because there are aberrant expression of markers like loss of CD19, overexpression of 56, 28, and 117, and loss of CD27 and CD81. So these are aberrant expression. And clonality because they all almost 99% shows light chain, kappa light chain expression, cytoplasmic or intracellular. Okay. Now look at the bone marrow biopsy. You can see the bone marrow biopsy. There are split of plasma cells here. And on CD138 expression, you can see that these all sheets of plasma cells are highlighted. So we have done we have done cytogenetics, and cytogenetics has come out to be negative for all these translocation which are commonly used for especially chromosome 14, where you have genes for heavy chains immunoglobulins. Okay, so you have this IgG gene located on chromosome 14. So that's why, and this is a disease of immunoglobulin, the abnormalities. So we see the abnormalities or mutations, translocation on chromosome 14. So you can see the commonest is that these are 414, 14, 16, 11, 14, and the other abnormalities which include deletion of or monosomy 13, TP53 mutation, and 1q amplification or deletion, but did not show any evidence of even there was no evidence of hyperdiploidy in this patient. So to summarize, this patient was a 46-year male which presented with backache and weakness and anemia. There were increased globulin levels. There was increased serum urine and creatine levels. There were high levels of IgG kappa, type M protein levels, high levels of urine kappa levels. There were lytic lesions in the skull as well as the sclerotic lesion. And bone marrow aspirate shows 46% clonal plasma cells, and bone marrow biopsy had sheets of plasma cells. So what is our diagnosis? Dr. Malenga, what's your diagnosis?
I think looking at the symptoms and also the findings, yeah, I think the diagnosis is multiple myeloma because it satisfies the criteria for the diagnosis.
Perfect, correct. So this patient's diagnosis is multiple myeloma. So the interesting fact is look at this term of myeloma was coined by Ristitsky from Ukraine. Now Ukraine, all this Kiev and Ukraine is now everybody is knows since because of this war. So the myeloma came from the Greek word, basically means marrow cells. And multiple myeloma came because of the first patient was a 47-year gentleman whose autopsy showed 8 separate tumors because there were multiple soft tissue soft in consistency, reddish tumors were there. That's why multiple word came, and myeloma because it indicates marrow tumor, so marrow cells. So that's how the term multiple myeloma came into the existence. Okay, so let's see what is multiple myeloma. It's a genetically heterogeneous group of disorder. It is basically B cell neoplasm, which is characterized by clonal proliferation of plasma cells and which produces a lot of monoclonal immunoglobulin M protein, which causes end organ damage, leading to hypercalcemia, renal insufficiency, anemia, and bony lesions, including pathological fractures, which indicates our CRAP criteria. So these are the criteria, for which is myeloma defining events, basically called as myeloma defining events, which indicates hypercalcemia. If you look at the levels more than 1 milligram per deciliter, renal insufficiency, which can be identified by using creatinine clearance level, anemia, hemoglobin, if more than if there is decrease in hemoglobin levels more than 2 gram per liter per deciliter, or more than 20 gram per deciliter decrease, than the normal lower limit of a person or for the age and sex, then it is defined as anemia. And if you have bone lytic lesions, by using either radiology, X-ray, or CT scan or PET scan. And there are few new criteria which are recently defined. It's not recently because almost 7 or 8 years, which also indicates that these criteria which include even there is no these criteria, this anemia, hypercalcemia, lytic lesion, even those are not there. But if you have clonal bone marrow plasma cells more than 50%, or if you have light chain ratio more than 100, or even if you have one or more than one focal lesions in MRI study, can be also considered as myeloma. So this criteria now has been defined, not only CRAB but slim CRAB. So as for 60% of plasma cells in bone marrow, LI for light chains, ratio more than 100, and lytic lesion in MRI more than one focal lesions. So in addition, so these are the new relatively new criteria for the myeloma defining events. And this is WHO has given out the same slim CRAB criteria in the updated 2022 version. Okay, so we have discussed. I'm skipping these already. These are the little incidents of M protein. You can detect the M protein almost 97 to 99% of myeloma. Only less than 1 to 3% cases are non-producing, non-secretory myeloma, non-secretory which do not secrete this protein. So you may not detect protein, but still the disease can be there. The commonest, the globulin is IgG, followed by IgA, and then other light chain, and then other IgE and IgD. Okay. Now, anybody has aware of this picture? Anyone has seen any conference, attended the myeloma conference or this one? So this is a picture of Sarah Newberry. She was 39-year-old lady who was first reported patients of multiple myeloma. So we can see how much the lytic lesions, and because of the multiple fracture, she had developed a lot of disability. And that time the myeloma was not used the term; it was used as a mollitis osseum. This was the old name for multiple myeloma. Okay, so this is our question again. So myeloma define, which are the myeloma defining events except following? Anyone?
C.
This is not myeloma.
C. Anemia, anemia, hemoglobin less than 100 grams per deciliter. This is not the myeloma.
That is right. So okay, this is not your answer is wrong. You can see the anemia. Of course, it's anemia. Your CRAB criteria. What is A? A is anemia, right? So M protein does not define the myeloma defining events, because M protein can be present in other plasma cell neoplasms also. You have smoldering myeloma, you have IgM plasmacytoma, you have MGUS. Other plasma cell neoplasm can also have M protein. So it is not myeloma defining. A myeloma defining event is slim CRAB. Okay, we have just discussed. Okay. Okay, so laboratory. What is the role of laboratory in the diagnosis in myeloma? Is the diagnostics, prognostication, and monitoring. And we have seen the diagnostic already. Now let's look at prognostication. So prognostication can be done by different laboratory techniques. One is international staging system, which predominantly depend on the serum protein levels. Then we have cytogenetics, we have LDH level, and flow cytometry also used. So flow cytometric immunophenotyping is also used for prognostication. So if you look at ISS staging, that is international staging system, quite old staging system, which is sometimes or some centers or sometimes difficult to follow, but it is being used internationally. So I'm going to describe. We have three stages: stage 1, stage 2, and stage 3. The stage 1, where we have serum beta 2 microglobulin less than 3.5 and serum albumin is more than 3.5 gram per deciliter. And stage 3, where we have serum beta 2 microglobulin more than 5.5 milligram per liter. And the stage where it does not meet with 1 or 3 is all those patients are categorized into stage 2 disease. If you look at the cytogenetic on fish or the conventional cytogenetic, if we have translocation 414, 1416 or deletion 17p3 13, that is deletion 17p or TP53 mutation, this is considered as high risk. Now one more abnormality is also added, that is 1q gain, which is considered high risk, and the rest of our standard risk cytogenetic abnormalities. Okay, so these are the different pathogenic abnormalities which are commonly involved in myeloma, and the genes which is involved and there is frequency. This is from the updated to the WHO 2022. But if you look at here, predominantly chromosome 14 is involved everywhere. You can see the chromosome 14, and then hyperdiploidy is also a significant group of myeloma with hyperdiploidy, which comprise almost 50% of myeloma disease. And these are different cytogenetic pictures. You can see the fish, this slide shared by Dr. Amisha Shah. Thank you to Dr. Amisha. So you can see here the one signal is lost, indicate from the chromosome 17, and then you have one additional signal is for the 1q. You can see there are three signals of chromosome 1q. So these are all fish probes which gives the different signals. The same way there is a translocation between chromosome 4 and 14, so you can see there are two signals are fusing here. You can see there is a fusion between the two signals. The same way 11-14 fusion is there, again 14-16 fusion is there. So these are the commonly done cytogenetic test. And you can see this is conventional flow cytometry, which is shared by the slide shared by Dr. Mayur Pariyar from TMC Kolkata. And you can see there is an increased number of chromosomes, 1, 6, 7, 9, 10, 11, 17, 15. So this is which indicates there's more than 60 chromosomes in this patient. And recently, actually not recently, but in 2015, there was a revised international staging system, which is further defined, which included cytogenetics abnormality in it and LDH levels also. So you can see that this revised ISS staging has been which includes ISS staging 1 and standard risk by cytogenetics. Then and stage 3 has ISS stage 3 and either of any high risk cytogenetics, that is translocation 414, 1416 or deletion 15 or TP53 mutation. So that included ISS stage 3. So this was revised. Now there is additional R2, that is re-revised or second revision of this ISS staging has come, which they have included chromosome 1q gain as a part of abnormality to the chromosomal abnormality or by fish. So this is R2, and they are on verge of revising the third revision, which will most probably include circulating plasma cell levels, high levels of plasma cells, to define high risk myeloma. Now, if you look at the flow cytometric options for plasma myeloma, so we have different markers. Due to time, I will not go into the detail, but most important is the ploidy, because hyperdiploidy indicates standard risk myeloma, as well as higher plasma cell index, that is the proliferating cells, also indicate high risk myeloma. Then if you have MGAS-like signature, and as I mentioned, high levels of circulating clonal plasma cells in the peripheral blood, that is above 0.01%, also define high risk myeloma. Okay. This is just an example to show you. We do by using flow cytometry. So we identify plasma cells by using 38 and loss of 45, and then we look at its G1 and G2 peak, and then we compare the G1 peak where we with the normal lymphocytes, and then or the normal cells like granulocytes or monocytes, and then we calculate the index. And if DNA index is more than 1.16 or 1.06, it's called as hyperdiploid. To be more careful, we usually take 1.2 to define hyperdiploidy. And in this figure, you can see it was 1.3. And this is the close picture. You can see the granulocytes and lymphocytes showing the clearly different peak as compared to the myeloma peak, which is clearly showing the hyperdiploidy, indicating high DNA index. So basically, flow cytometry binds with the DNA, which is present in the chromosome. So because there is increased number of chromosomes, you have higher signals of DNA binding dye. Also, by flow cytometry, we can also identify FGFR3 overexpression, which indicates translocation 414, 14-4. And we can also look at one of the major role of flow cytometry to evaluate minimal residual disease, which MRD is basically nothing but the number of cells, tumor cells, which are left over after giving initial therapy. So patient receive initial induction therapy, and at the end of induction therapy, we look at the leftover disease. And if we have leftover disease, that means the tumor cells which were not killed by the initial induction therapy, which indicates resistance to the given therapy, which ultimately causes the relapse of the disease. And that's why it is also one of the major prognostic factor in myeloma also. Okay, so this is just example. You can see we identified the plasma cells here, and these are the abnormal plasma cells which are 19 negative, 56 positive. You can see the 45 also lots, and they are all kappa restricted plasma cells. So in this case, the MRD was 0.0004%, that is 4 cells in 1 million cells. So final diagnosis in this patient was multiple myeloma with revised ISS staging of 2, stage 2. So intermediate risk myeloma. So coming to our next question, which one of the following is high risk myeloma feature? So let me ask Jigisha. You can look at the following 4 options are there. Which one of the feature is high risk myeloma feature? Jigisha, can you hear me? Anyway, Zoya.
The translocation between 4 and 4 chromosome 4 and 14.
Correct. So this is the one which defines high risk myeloma. Okay. Now this, as I mentioned, there are variants, and you can see there are some variants. Even plasmablastic myeloma we've already discussed, and we can have some crystal storing histiocytes and all. Okay, so I'll just skip this case. Coming to the second case, I'll request Dr. Neeraj to take over from here for the second case.
So thank you, Prashant. I think Prashant has taken you through a lot of details about the diagnosis of myeloma. Then he's discussed with respect to the various prognostic marker, diagnostic markers, cytogenetics, flow ploidy, MRD, and I will try to highlight one aspect through this case, which taught us a lot of things. This was a 83-year-old male who presented over the last 1 year with an abdominal distension, weakness. There was low hemoglobin, and the patient was taking antitubercular treatment for 3 months. On examination, he was afebrile, and there were cervical matted nodes of the size 3 to 4 centimeters. And on examinations, there was no organomegaly. There was slight tenderness over the spine. This is an 83-year-old male. And on radiological investigations, we found there was hypoechoic lesions in the liver, there was splenomegaly, left mild hydronephrosis, and on the MRI spine, there was compression of C4 and C5 vertebrae. There was bilateral multiple enlarged discrete enhancing cervical nodes, some showing necrosis. Next slide. And on the lab evaluation, if you look at the various parameters, you see that hemoglobin was normal, 11.4. TLC was slightly high, 15,000 with 58% polymorphs, eosinophil, lymphocytes 27%, there were 11% monocytes, platelet counts 1.5 lakh. The total bilirubin 0.5, total protein 7.4, albumin was on the lower side 1.5, SGOT, SGPT pretty normal, creatinine 1.1, sodium and potassium normal, and calcium normal, LDH 572. So we were evaluating a case of lymphadenopathy not responding to ATT, and since there was a lymph node, and traditionally whenever there is a lymphadenopathy, you would like to do a lymph node biopsy for that case, and this is what the lymph node biopsy looked like. On the lymph node biopsy, you could see that there is loss of architecture, and there was ill-defined nodular pattern was seen. So the slides are not very clear, but I can just take you through that. This was a thickened capsule, loss of architecture, and you could see the nodularity on this on the lymph node. And on high power, you could see a polymorphous infiltrate, and which included lymphocyte, plasma cells, eosinophils, and centrally a large cell with eosinophilic prominent nucleoli. Anybody would like to comment on the diagnosis, seeing the things that I've mentioned? 83-year-old male on ATT, not responding to treatment, lymph node biopsy showing a nodular pattern with polymorphous infiltrate and a large cell with central prominent nucleoli, eosinophilic nucleoli. Any diagnosis you have? Anyone?
Yes. So, seeing the information we have, I think the diagnosis would be a Hodgkin's lymphoma.
Very right. Very right.
Tubular sclerosis.
So Hodgkin lymphoma was suspected in this particular case. So how would you confirm? What sort of markers you would use on immunohistochemistry to confirm that this is a Hodgkin lymphoma, what panel of markers you would use?
CD3s, PAX5, CD45, and CD30.
Okay, very right. So traditionally, based on morphology, you approach whether it is nodular or there is, and you start with CD320 Ki, the usual panel for lymphomas. If you see larger cells, then you add CD30 in that, and if it is a blastic mark, you add TDT to the panel. So in this particular case, as it was a nodular infiltrate and you were seeing large, eosinophilic RS-like cells, so we added a panel of markers which included CD320 Ki along with CD30, and this is how the immunohistochemistry looked like. So CD3 was nicely positive in the small cells in the background. CD30 highlighted the large cells, the RS-like cells were positive for CD30. And whenever you are interpreting CD30, you need to look at the positivity. How is the positivity? It is Golgi zone and membranous positivity for CD30. Just with no Golgi zone and interpreting CD30 would lead to wrong diagnosis. So looking at the large cells and the positivity of CD30 is very, very important in that. And these large cells, RS-like cells, are CD45 negative. You can see here CD45 nicely showing that there is no CD45 in these cells, and also these cells were weak PAX5 positive, but very weakly positive. And this, when you say weak, this is in comparison to the surrounding B cells highlighted by CD20 or PAX5. So this is a strong PAX5 cells, and if you compare the large cells, they are weak. So that is how you interpret the immunohistochemistry. So CD20 was negative. And so if I would just summarize the IHC findings, so this was background was CD3 positive, the large cells were 30 positive, weak PAX5 positive, 45 was negative, CD20 was negative in these large cells, and EBV and other markers have not been shown, but they were negative. Yes. So since the suspicion was Hodgkin, and now even the marker wise, we were looking more in line with the diagnosis of Hodgkin. And this is the bone marrow biopsy for that patient, where you can see a focus, not very well highlighted, but there is a focus hypercellular marrow, and within that hypercellular marrow, you can see a focus of or aggregate of cells. Can you go to the next slide, please? Yeah, and you can see that within this focus of cells, you have small lymphoid cells, some plasma cells, and there are occasional large cells looking like RS-like cells, but not very typically seen. Next slide. Yes. So this is a case of Hodgkin, and we are looking at the IHC in the bone marrow. That focus is showing CD3 positive cells, and those large cells are CD30 positive. So can anyone make the diagnosis now?
Sir, Hodgkin lymphoma with smoldering myeloma.
I have not come to smoldering myelomas yet. So I'm just showing you the Hodgkin lymphoma involvement in the bone marrow. That's what I'm trying to show you. Okay. Next slide. So up till now, this was a classical Hodgkin lymphoma nodular sclerosis involving the bone marrow. Okay, this is what the diagnosis was. So just wait here, So if you see in this particular case, we were totally misled. This patient presented with there was a light lesion and there was a lymphadenopathy. So we were dealing with lymphadenopathy, and we diagnosed this case as Hodgkin lymphoma involving the marrow. Until one of our colleagues, seeing that there is a light lesion in that, one of our colleagues, Dr. Saurav, he ordered serum protein electrophoresis along with the bone marrow biopsy. And you see here, there is a moderate M band. There is an M band and the spike of 3.1 gram per deciliter in the gamma region. So you can see we were evaluating a case of lymphadenopathy and a light lesion, had a diagnosis of classical Hodgkin lymphoma involving bone marrow, very rightly so, until we got these findings that there is an M band, and that is where our problem started. And that is also very important, to giving due importance to the clinical history. If you are ignoring clinical history and not approaching the cases, you can go in a totally different direction. So now he was asking the question that, this is a case of Hodgkin lymphoma, and how will you explain paraproteinemia, or how will you explain M band in this particular case? And that is where we were evaluating. So further evaluation showed that this paraprotein was IgG type, and now we were evaluating that this is a case of Hodgkin lymphoma with paraproteinemia, and this is retrospective. This is retrospective bone marrow biopsy. Can anyone see some things here, or try to see what are the things being highlighted in the arrow, or you can see anything?
So these are the plasma cells?
Yeah, these are all the plasma cells which we had initially missed out. So seeing that there is a marrow involvement in the Hodgkin lymphoma, we did not adequately give importance to the plasma cells, which are usually missed out. And you see in the cases of Hodgkin bone marrow, the reactive plasma cells. But here, this was a retrospective evaluation, and you saw the plasma cells. And then we tried to characterize those plasma cells. It was highlighted by CD138 on immunohistochemistry. So and it was approximately 15 to 20%. So since Prashant had shown you the markers which we try to use it on flow cytometry, which includes CD38, 138, 27, 81. A lot of markers are available. On immunohistochemistry, CD138 is sort of one of the most specific markers available, which you use it along with CD38 to characterize those plasma cells. But that alone is not sufficient to say that these are plasma cells, because you can get some of the other conditions as well. I think can you share screen? This is
Hello.
Yeah. So those plasma cells highlighted by 138, they were now we wanted to know whether they are clonal or not. Prashant showed on flow cytometry, kappa and lambda, chains being utilized for clonality. Similarly, on IHC we have kappa and lambda IHC or ISH stain, and this is the slides of the IHC where you can see that. Can you previous slide? Where you can see that these slides look lambda restricted, and subsequently next slide. So these plasma cells were 56 positive. Next slide. So now we were dealing with the classical Hodgkin lymphoma with a plasma cell neoplasm. So anybody would like to say what type of plasma cells we were looking at? Now you have gone through all the different types of plasma cells. Can anyone highlight what type of plasma cell this is? Neoplasm this is? Okay, next slide. Next, but yeah. So this is just to summarize, whatever we have seen in this particular case. So there was no myeloma defining event in this particular case. There were clonal plasma cells on bone marrow biopsy, which was around 10 to 15%. This was more than 10%, and an M protein which was 3 grams per deciliter. So we were dealing with a smoldering or an asymptomatic plasma cell neoplasms along with the classical Hodgkin lymphoma, which was involving the bone marrow. Next slide. So this is the definition of smoldering myeloma, and both the conditions or the criteria must be met. That is serum monoclonal IgG immunoglobulin more than 3 grams, and absence of any myeloma defining events or amyloidosis in this particular case. And the risk of progression to myeloma is usually 10% per year. Next slide. So we come to the question, Dr. Deepika, would you like to take up which is the following is the specific marker for plasma cells?
CD30, 138 and CD38.
Yeah, so CD138 is one, also known as Indican 1, is one of the specific markers, but not very sensitive in picking up. You need additional markers to be able to characterize those plasma cells very clearly. As Prashant has shown that on flow, a lot of markers are available which you can use to characterize, to identify, and then to define the clonality. But when you're using on immunohistochemistry, we need to be careful that if you have history and if you have the clinical details, then probably 138, 1 or 2 markers is sufficient. But if there are no details available, then you need minimum 2 markers to demonstrate these plasma cells, and subsequently you need to demonstrate that these are abnormal by using various markers like 56, and these are clonal as shown by immunohistochemistry. So next slide. So we come to the case 3, and I would request Prashant to take this up again.
Thank you, Neeraj. So let's go to our third case. Now, this is a case we have a patient, 63-year-old male patient, from Ghatkopar, that is Mumbai, a retired worker from the aluminum casting factory, presented with headache, vomiting, imbalance while walking, hearing impairment in the right ear since last 5 months. There is decreased vision also in right eye since 1 month. But there is no history of seizure or trauma, head trauma or anything, head injuries. So this patient, because there are patients has skin symptoms like headache, vomiting, imbalance in walking, which looks like neural disease, vertigo, hearing impairment, vision, and everything. So patients investigated for CNS symptoms. So the MRI brain was done, and they did not find any abnormality. MRI spine was also done. So they have found that there is bulges at C5 to C between C5 and C6, C6, C7, as well as L4 and L5 levels. So they have also done CT and MRI, and which shows generalized mild cerebral hypertrophy with chronic ischemic changes. And X-ray showed light ligation in C3 vertebra. So this was a patient which presented during COVID. So the patient, even they have suspected because it was a pandemic. So they were also, the patient was from the good family and financial background. So they have done the HRCT to see if, because COVID test was negative, but there was a few cases reported who had on HRCT COVID-like finding, but tests were negative. So they have done. So they had HRCT a chest, and they have found there was like approximately 4 centimeter density in the base of the right lung. So this is a history. On CBC, when you looked at CBC, hemoglobin looked normal. In fact, RBC1 was in a higher level. The platelets were also slightly higher levels, and WC count also mildly high levels, kind of. So there were no significant abnormality in CBCs. So biochemistry was done in this patient, and on biochemistry, you can see there were hardly any abnormality, other than some sodium and chloride levels, altered levels of those. But patients, again, because the patient had, on MRI, the patient had disc and bulges at the level of at multiple levels in this one. So the patient's M protein was also done, and on M protein they have detected a small level of, you see, there was small band was there in the beta region. Usually it comes in gamma region, but sometimes can be seen into the beta region. So it's a small level of 1.3 gram deciliter was there. And if you look at immunofixation, it was of, you can see the lambda light chain was increased, lambda kind of, and IgG level, but rest and IgA level was increased. You can see the Ig level was almost double, and there was lambda was increased, and even the free light chain ratio showed the increase level in the lambda. You can see the lambda levels increased. So that was finding. These were the finding, and so because there was some increase in the M protein, so bone marrow was also done. And anybody want to describe bone marrow, Dr. Deepika? What do you see in this bone marrow smear? I'll say it was normocellular marrow.
This is a slightly hypercellular marrow which is showing plasma cells.
So according to
No.
you, is the plasma cell increase or they are normal level or what? So there are few plasma cells that you can see here. There is this plasma cell, this plasma cell. Let me.
Few plasma.
Yeah, so there are few plasma cells were there. You can see there, but they're very few. If you look at the plasma cell percentage, less than or probably less than 5% or 5 to 10%, but definitely less than 10%. You can see this was the plasma cell, the closer view. And so the flow cytometry was done because plasma cells are low in number. You can see we have identified plasma cells by using 138 level. And as this shows, report shows, you can have orange population, which is shows 19 loss, 56 gain, that is aberrancy, even the 27 slightly dimmer. 81 looks okay, but 28 and again 117 was positive, which indicates clear abnormality, and also had normal plasma cells, which shows polyclonality. You can see here, and this 72% out of total plasma cells. If you took total plasma cells, which were 0.1%, if you take them and if you identify out of them, the 72% plasma cells showed abnormalities like loss of 19, overexpression of 117, 28, and 56, and lambda light chain restriction, which is also confirmed by the serum electrophoresis and investigation. So biopsy was done. On biopsy, you can see the biopsy looks normocellular. There are very few prominent plasma cells here. You can see the closer view, but you can see there are a few plasma cells, especially increased interstitial, but they are not forming in clusters or shades. There are a few scattered plasma cells. You can see there are 4 plasma cells here, 2 here, 2, 3 here, 1 on 2 here. So those plasma cells are there. So on CD138, as Dr. Neeraj has shown, that you have very small scattered cluster plasma cells, small cluster and scattered plasma cells. So approximately less than 5% probably these are the plasma cells present in this marrow. So meanwhile, so we had a patient who had seen a symptom, right? Okay, and then HRCT showed a small mass or dense hyperdense lesion in lungs, right lung. But incidentally, because on M protein, the patient's workup was done and there was backache, so M protein was also investigated, which showed M protein level. But M plasma cells are very few in number, less than 10%. The scattered plasma cells patient did not have any abnormal, creatine levels or anything. There was no lytic lesion. There was no anemia. So the plasma cells were not increased. Potassium, calcium levels were normal. And so this is this HRCT. You can see there was this mass region, and so biopsy was done from that region, and it has turned out to be adenocarcinoma of lung. So that was the diagnosis from the lesion. So what about the M protein levels? There were a few plasma cells. Anybody can guess what can be there based on the history we have and the findings we have? Jikisha or Deepika? Want to take a guess? This is a case of adenocarcinoma. But how do you explain where we can fit this M protein with low level plasma cells and no symptoms for the myeloma? No myeloma defining events basically.
Waldenström macroglobulin.
Waldenström, that is lymphoplasmic lymphoma. So you have to have, okay, that is one, but then we have to have abnormal clonal B cells.
One more
Gammopathy of undetermined significance.
Yeah,
different significance.
one is one of the region where you can have low level M protein and low level plasma cells. That is monoclonal gammopathy of undetermined significance. That's MGUS, as well as you can have smoldering myeloma. But in smoldering myeloma, you should have more than 10% plasma cells, but in bone marrow. But in this case, they were less than 10%. So probably we are dealing with this patient's CSF also had involvement from the lung, and which explain, you can see the CSF has tumor adenocarcinoma cells, which explains the patient has CNS symptoms. So it was CSF involvement by metastatic adenocarcinoma. That's why the patient has seen the symptoms. But the M protein has the plasma cells. And M protein was just in which we have because of monoclonal gammopathy of undetermined significance, and it was non-IgM type. It was IgG type, right? So let's look at how the MGUS are classified. MGUS, there are 2 types, or maybe it's 3, 4 types of MGUS now. We have non-IgM, which is IgG or other than IgG type of MGUS, which is defined by having the monoclonal protein less than 30 gram per liter or 3 gram per deciliter. Either 3 gram per deciliter or 30 gram per liter. Then the bone marrow plasma cells should be less than clonal bone marrow plasma cells. So you have to confirm that those plasma cells which you are seeing should be clonal. And then absence of end-organ criteria of or myeloma defining criteria, that is slim crab. All those 7 criteria should not be there, any one of them. IgM, of course, if you have IgM kind of monoclonal protein in the same everything, then it's IgM gammopathy. Then if you have light chain aberrancies, that is increased light chain, at the same time the similar kind of features. If you have normal level 0.26 to 1.65, but if you have deranged normal levels, then you can also consider light chain monoclonal gammopathy of undetermined significance. And then there is MGUS of renal significance or monoclonal gammopathy of renal significance, that is MGRS. Where you have renal symptoms which indicated by increased creatine or DDR. So if you look at the disease biology, all myeloma or plasma cell neoplasm arises from the MGUS. So at one stage they are in MGUS, and and then eventually based on the collection of genetic events, and the patients develop smoldering myeloma or myeloma. So if you look at the rate of progression of MGUS is 1% per year. That means in 1 year, if you detect there are 100 cases of MGUS, that out of them 1% can develop myeloma in a year, 1 year. So that is 1% per year. The same way, smoldering myeloma has chances of progressing, that is 10%. So if you have 100 patients, out of them 10 patients can develop or can progress to multiple myeloma. Based on this is what this figures indicates. Okay. So if you look at the prevalence in the world, there is approximately 3% general population. If you take any population above 50 years, the incidence or the prevalence of this MGUS is 3%. And in India, we do not have general population-based registry, but there is a study from AIMS which they have done a hospital-based registry, means the patients or the people who visited the hospital, and they identified the incidence was 1.4. So overall incidence or prevalence of MGUS in India or the myeloma, the plasma cell neoplasm, is relatively lower as compared to the Caucasian population. Okay, so we have this. Now, the one interesting fact regarding this M spike. So if you look at the M spike, the detection was started based on the serum electrophoresis. The serum electrophoresis, the technique was first given by the Tiselius, Arne Tiselius of Sweden, who has also got Nobel Prize in chemistry. And this is the M spike was defined and identified by using this serum electrophoresis technique by Louis Longsworth from the Rockefeller Institute of New York. This was the old picture of in the Rockefeller Institute of New York, and the MGUS was identified and defined by Dr. Robert Kyle from Mayo Clinic, and it was published in 1960. First, whoever for the almost natural history of 241 cases, and this is his picture still alive. Okay, let's go to the case 4. We had a 54-year lady from Patna. She had no comorbidities. She had swelling in left side of forehead for last 5 months. There was some history of headache and vomiting, but no fatigue, no swelling elsewhere. Only one swelling. Okay. Now the patient's laboratory general investigation was done. The patient has hemoglobin of 10 gram per deciliter. If you look at in India, many females have 10 to 11 gram, which is close to normal levels. WBC was normal. Platelets, although they were slightly reduced, 90,000, and creatine levels were normal. So X-ray was done. You can see there was on head there was this lesion. So you can see that this lesion is highlighted by this here by this X-ray skull. This woman, you can see there is ornaments on the nose. Okay, so here our hemoglobin was 10.8, very close to the normal, especially for females in India, and everything looks normal. The platelet is even slightly reduced, but otherwise looks normal. The cell count. Now the biochemistry was done in this patient as a part of routine evaluation. Majority like creatine, uric acid, and potassium, sodium, potassium looks normal. But if you look at serum protein level, the total protein level was increased. That is 8.4 grams, slightly increased that too. But serum globulin level was significantly increased. The normal level is up to 3.5 gram, but here it was 5.5. The rest looks fine, although there were some altered levels of liver enzymes. So because our globulin levels were high, again electrophoresis was done, and you can see there was M spike, that is location M band was detected on serum electrophoresis of 2.8 gram of gamma region, and you can see on immunofixation there was the band was IgG, that is gamma region, and the lambda right chain restriction. Okay, so lambda and IgG, so a heavy chain, gamma heavy chain. And even the nephrometry has shown that increased IgG levels. You can see that the IgG levels was increased with increased lambda chain, and even free light chain shows high levels of lambda chain. Right. Anybody want to take a guess? What could be the diagnosis at this stage?
So plasmacytoma. Probably.
Yeah, because we have one localized lesion, no other myeloma defining features. We have M protein levels which are detected in this. But of course, to confirm, we have to do what we have to do to confirm.
The marker.
What?
CD138, CD38.
Where do you want to do? On which tissue you want to do?
So we have to
The
biopsy it.
lesion is shown in.
Yeah, so Dr. Malinga has said very rightly. So because there is a lesion, localized lesion on the scalp of the female, the best way, and it is easily approachable, best way is to do biopsy it and then confirm whether you are dealing with plasmacytoma. Right. So the biopsy was done, and this is biopsy. You can see the sheets of cells which are round. Let's see the closer look. You can see this is the closer, and you can see if you look clearly, they are all plasma cells or plasmacytoid cells. We can see because there can be other things also which can look like plasma cells, but there are sheets of plasmacytoid cells, which is technically as abundant eosinophilic cytoplasm here. And so to confirm, the IQ was done. CD138, all cells were CD138 positive, confirming that this was a plasma cell lesion, showing some light chain. So kappa and lambda was not really working well, but still there was some background with lambda light chain, and kappa was completely blind. And we had M protein with increased free light lambda light chain, right? So bone marrow was done. So do we need bone marrow in this disease? Do we need to do bone marrow in this, or is it enough? The investigations are enough.
So in some cases, there are minimal bone marrow involvement.
Yes, minimal marrow involvement, but still, if we want to, because we have one lesion, but still we want to see if there are plasma cells sheets of, because one of the criteria, if more than 60% plasma cells are there, still we can define myeloma, isn't it? So that's why we have to do bone marrow. So bone marrow was done. Bone marrow was normocellular, but you can see there were some plasma cells, binucleated plasma cells were there. So plasma cells were increased relatively, although they were not up to 60%, but definitely between 5 to 10%. Okay. So, but that these are abnormal plasma cells, we have to confirm their clonality. So immunofetal was done to confirm the clonality, and on immunofetal again we identified plasma cell by using CD38, 138, and you can see there was very few normal plasma cells which showed 19 positive, but the majority of plasma cells showed 19 lost. CD56 expression, CD45 was lost, CD81 was down-regulated, CD27 was lost, and CD28 was positive, although CD11 was not there, and they all were lambda restricted. So we had majority of plasma cells, which in bone marrow of the total plasma cells, although the plasma cells were very few. So one thing we have to notice, usually by flow cytometry, the plasma cells and total plasma cells are relatively lower, almost 10 times lower than that of the way you see in bone marrow, because we lose plasma cells during processing for immunophenotyping. So if usually you have 3% plasma cell by morphology, you will see 0.3% by flow. So if you're less, or even less than that. So it is usual dictum. Bone marrow biopsy was also done. Bone marrow biopsy showed normal cellularity, normal architecture. The closer we showed some increased plasma cells. You can see there are few plasma cells here, and they're scattered increased plasma cells. On CD138, definitely there were more than 10% plasma cells. Okay, so to summarize, this patient had a 50-year-old lady which had swelling over head, and then she had radiologically there was tumor, although there were no lytic lesion. Biochemistry definitely was abnormal, showing increased globulin levels with IgG, lambda light chain protein on electrophoresis and immunofixation and nephelometry. And bone marrow biopsy showed plasmacytoma, and bone marrow had plasma cells, which on counting, I think they mentioned 10 less than 10% plasma cells, so probably 8-9% plasma cells. So there was no myeloma defining events. So this was a case of, as Deepika said, plasmacytoma with minimal bone marrow involvement. Let's look at some literature on bone marrow plasmacytoma. So we have, as I mentioned, two types of plasmacytoma: solitary plasmacytoma and solitary plasmacytoma. Also, we have medullary and extramedullary plasmacytoma. And so, how do we define the criteria? Is for the biopsy-prone solitary lesion. There should be no bone marrow in solitary plasmacytoma. There should not be any bone marrow involvement. Then normal skeletal survey, MRI, including MRI, CT scan, as well as X-ray, and there should be no evidence of any myeloma defining evidence, that is slim crab. And we have another entity, that is solitary plasmacytoma with minimal bone marrow involvement. The reason is the incidence of increase in this category of plasmacytoma with minimal bone marrow. There are high chances or high risk of progressing to multiple myeloma, and that's why they have defined this entity separately. But if you have plasmacytoma with more than 10% plasma cells, then we have to consider it as a multiple myeloma, because the high rate of progression, more than 10% chances of progression to multiple myeloma within 3 years. Okay. So these are again similar same things which has been updated in WHO 2020. Now this is a picture of myeloma cells which were carved on the wooden plate by Dr. Dalrymple in 1846. He was basically a surgeon, but he had looked at the cells under microscope. He was a surgeon who was a member of microscopic society. We just look into the microscope and we have seen these cells. So this is the first documented picture of plasma cells, although it was drawn by on the wooden shelf. Okay, so let's go to next case. We had a case, 35-year male patient from Patna. She was symptomatic for last 2 months only. She had dry cough last 2 months, easy fatigability, significant weight loss, 9 kg in 6 months. People wish nowadays. Anyway, so no fever and no bleeding. Okay. Local laboratory investigation was done. CBC showed hemoglobin very low, that is 5.6 only. Platelets were reduced, although the TLC was high, 46,000 count. Okay, low platelet, that is thrombocytopenia, low hemoglobin, anemia, clearly anemia. ESR was very high. ESR was also high. And if you look at total protein was 9.5 gram, albumin was 3.2 gram. CM creatinine levels very high, 8.2. Okay, and even the urine albumin was positive, and there were 2 10 WBCs in urine. Now the patient came to the hospital, and we have done the CBC. You can see the CBC again, hemoglobin level was low, with high WBC count, almost 24,000 was WBC count, with low platelet, that is only 70,000 platelet count. And if you look at the CBC, there were large unstained cells were identified. Now these 5-parameter advanced CBC cell counters can also show you large unstained cells, which they could not fit in any type of this neutrophil lymphocyte monocyte area. They were almost 44%. Okay. Let's go to, this is the peripheral smear. You can see the peripheral smear. As you can see, there are rule of formation in the background. Let's do the closer view. So the closer view, anyway, Zoya, can you see what are these cells? Yeah.
So plasma cells.
All right. So you can see there are plasmacytoid cells are there. There's clearly some cells even showing the prominent nucleoli. Right. So you have circulation, plasma cells in the circulation, and this is, you can see the 40 power oil immersion. If you see so many cells, definitely the count is increased. And if you look at carefully, almost 50% or 30 to 40% cells look like these are the plasma cells. Okay, so again, routine biochemistry was done here. You can see as it was done outside, the creatinine and urea level and uric acid levels were increased, indicating compromised renal function. Again, albumin was very low, globulins were increased significantly, and even the LDH levels were very high. That is high. And serum electrophoresis was done. Again, we have found M protein level of 7 gram in IgG, and on nephelometry, IgG proteins were very, very high, and they were all lambda. You can see the lambda light chain, showing the lambda light chain. So lambda kind of IgG proteins were increased. So flow was done in peripheral blood only. With again, the plasma cells were identified by using CD38 and 138. All plasma cells are 19 negative, but these plasma cells did not show CD56 expression. There is loss of CD81 and 27. There was some expression of 28 was there, and they all were lambda restricted. So all plasma cells identified in the peripheral blood, they were abnormal clonal plasma cells. So our diagnosis is
Plasma cell leukemia.
Plasma cell leukemia. Anybody knows the criteria for plasma cell leukemia?
So greater than 20% plasma cells in peripheral blood smear.
20%, right? So 20% plasma cell is our traditional definition. Okay, so diagnosis of plasma cell leukemia. Now, the old definition, as Deepika, I think Deepika also has mentioned, that circulating plasma cell more than 20% of total WBC, or if your absolute count of 2000 per microliter, or is also considered as plasma cell leukemia. But this is old definition. Now we have additional new definition of plasma cell leukemia. Recently, the multiple studies have shown if you have even more than 5% abnormal clonal circulating plasma cells, they behave, or their outcome after given therapy is same that of those like 20% plasma cells, and that's why they have given the new definition for plasma cells. The International Myeloma Working Group has given, where the cutoff is more or equal to the 5% of clonal plasma in the circulation. Okay, so this is new definition. No more 20% plasma cell; it is 5%. So coming to our next question, I have already shown in one of my slides. Anybody know which is the normal range of serum free light chain ratio?
A, sir, 0.26 to 1.65.
That is correct. So this is our normal range, 0.26 to 1.65. That's the normal range. Okay, next case. I think this is Neeraj case. I would request Dr. Neeraj to go with the next. Go ahead with the next case.
So this was a 60-year-old male who was a smoker for 10 years, and he presented with fetal edema and facious puffiness since 2 years. There was history of oliguria since 2 to 3 months, and he came with the history of neck pain since 1 week. Was being evaluated for renal failure, and you could see the findings here. There was anemia, platelet count was normal, TLC was around 10,000, and the various other parameters, which included creatinine of 2.5, and the SGOT, SGPT 22 and 20, alkaline phosphatase 158, 2.7, LDH was 610, calcium was 8.7. The next slide, please. So these findings were confirmed. I think there was anemia, and on the other finding was there was lymphocytes was around 40% of the total 10,000 total count. And as had been earlier documented, so serum urea was slightly higher, creatinine was high. There was a slight increase in the globulins, and hence next slide. This was the serum protein electrophoresis was done, and you could see a monoclonal bank was in the gamma region, and the total urine total protein was elevated 6,780 with a free light chain of 129 and a lambda of 112, and there was slight deranged in the AG ratio reversal was there. A bone marrow was done, and this is how the bone marrow looked like. It was slightly hypercellular, mildly hypercellular, the fragments, and there was scattered plasma cells, not increased, too much increase, and so around 3 to 4% plasma cells were there, and you could see the plasma cells, some binucleated forms, and with some with occasional nuclei, but nothing typically abnormal. So these were more mature-looking plasma cells. So whenever you are evaluating, plasma cell morphology forms an important component, and as mentioned earlier in the slides, binucleate forms, multinucleate forms, cells with prominent nuclei, loss of paranuclear half, plasma blasts. So different morphological forms you can see in the normal cells as well. But loss of a prominent nuclei, loss of perinuclear half, increased binucleate forms. So then those needs to be evaluated by different methods, and flow is one of the method to be evaluated. And here these plasma cells were were characterized on flow cytometry. And you can see here a proportion of these plasma cells which are highlighted in yellow orange. These plasma cells had an expression of 56 were 19 negative, 45 and 19 negative, and there was loss of 81, but they were expressing 27, loss of 81, then they were expressing 117, and 117 and 56 you can see, and these plasma cells were lambda restricted. So clearly there was a normal clone of plasma cells. Next slide. So anybody can pick up anything you want to highlight. So this is a bone marrow biopsy for that patients where being evaluated for renal failure, oliguria, and there were abnormal plasma cells, and on the bone marrow biopsy you are seeing this thing. Anybody wants to comment on that or highlight anything? Dr. Deepika, you want to mention anything? Yeah. So what you see, so what you're seeing is a pink eosinophilic material. This is extracellular material on the bone marrow biopsy, and this is how it looked like. It is a fibrillary amorphous material, and sometimes it can be very challenging to be able to diagnose amyloid or suspect amyloid. But bone marrow biopsy is one of the best methods to be able to diagnose that. Next slide. And so we saw the plasma cells. We saw there is an amorphous material, and then this is just to show the plasma cells are there in the bone marrow as well. Next slide. Yeah. So this is another view where Congo red was done. So traditionally, amyloid is a misfolding protein misfolding defect. The proteins are not usually folded well, and they deposit in the extracellular region as an amorphous fibrillary material. And this can happen sometimes when you're evaluating the bone marrow aspirates as well, and you can get a pink blobs. But bone marrow biopsy is what sort of helps you confirm. So whenever there is a plasma cell neoplasm suspected, please go look for thickening or see the thickening of the blood vessels, whether those are thickened or not. And you can see the amorphous material lying and the thickened blood vessels. So then you need to do special stains like Congo red, and on Congo red subsequently. Next slide. And this is there is a green birefringence which is seen, and this helps sort of confirm the findings of the amyloid. So there are different types of amyloid, and Congo red kind of highlights almost all the different types of amyloid that we see. Next slide. So this is another slide showing the same amorphous material, and next slide. So the Congo red being apple being birefringent, showing that this is very typically the amyloid is there. And whenever you are suspecting amyloid, it is very important to document what subtype of amyloid you are dealing with, whether it is treatable or not. So the commonest is the AL type of amyloid, but there are other types of amyloid. So having documented that this is an amyloid is very good. Subsequently, you need to categorize whether this is a treatable type of amyloid, and AL type being the commonest is usually highlighted by doing kappa and lambda immunostains. So if you do kappa and lambda immunostains, then they are typically highlighted by that, and then that helps you define that this is an AL type of amyloid. Moreover, also in this particular case, you have clonal plasma cells, and that also helps you share that okay, you are dealing with an AL type of amyloid. Next slide. So in this particular case, Prashant had shown you a lot of cytogenetic parameters or findings which that they are usually done in a case of myeloma or whenever you are suspecting a plasma cell neoplasm. So one important point I would like to add here is that whenever those abnormalities, molecular abnormalities or cytogenetic abnormalities you're looking for, those are to be done on the CD138 sorted plasma cells. So it is not on direct plasma cells, direct bone marrow you take and then start testing for these findings. It is this CD138 is enriched, meaning it is through an immunomagnetic bead-based method, or it is sorted, and subsequently the further fish markers are tested, and that is what helps you characterize them in a logical way. Otherwise, if you directly send your marrows or testing your marrows for your cytogenetic abnormalities, you're likely to miss out some of the abnormalities, like 1q amplification or TP53 deletions. So C138 sorting and subsequently testing for your cytogenetic abnormality is very critical. So in this particular case, there was no findings were seen, and so we had a diagnosis of AL type of amyloidosis, and these are some of the updated criteria for the diagnosis of myeloma, where you have presence of a amyloid-related systemic syndrome. Then you have positive staining by amyloid by Congo red in any of the tissues, and then there is evidence that the amyloid is light chain by direct examination of the amyloid using mass spectrometry-based proteomic analysis or immunoelectron microscopy, and evidence of monoclonal plasma cells. So next slide. So this flowchart is very important for you to remember how to approach amyloid. Whenever you are suspecting any amorphous material, usually the bone marrow biopsy or a fat pad biopsy is typically done. And this fat pad biopsy, whenever you are doing Congo red, this is a thick sections that you take for studying the Congo red. Lutein, smaller sections may not be able to demonstrate this Congo red. So either of the biopsies on H&E you suspect eosinophilic extracellular material, and you do Congo red, and with the typical apple green birefringence, and subsequently on IHC, there are markers available which can help you characterize what type of amyloid this is, either IHC by kappa and lambda, and subsequently there is an IHC available for AA protein as well. And also there is a genomic characterization also available for some of the amyloids like TTR and ApoE. So I'm just highlighting this the subtyping of the amyloid because some of the amyloids like TTR are treatable, and there are drugs and there are special drugs available which can so some of the mutations are there and some of the drugs are there which can be helpful in treating. So just leaving an amyloid as an amyloid may not be helpful. You need to characterize that and subtype that either using IHC. Some molecular markers are also available, and nowadays you have a mass spectrometry coming into this domain. That is one of the cheapest or one of the most established in this area, but it is not easily available for routine diagnosis. So routinely, immunohistochemistry is what is being utilized for this diagnosis. But if and where available, mass spectroscopy should be used for characterization of the amyloid into various subtypes. Next slide. So, Prashant, you would like to present this fact?
So, some interesting facts about amyloidosis. If you look at the amyloidosis, basically was described in 1639, very early, and based on the Lordacius change in the liver. So the term basically amyloid came from the botanist, a German botanist who defined amyloid because of the Lordacius change, which looks like in liver also. And it was the Rudolf Virchow who in 1854 used this term for human. And he also used that term not for myeloma, but he used that term for the nervous system. He's tried to paint the part of brain, the amyloidosis, and it was giving the similar kind of results. But later on, he mistaken the substance as a starch and called as amyloid, which indicates this, which basically the Latin word amylum. And from there, this word, the Lordaceous or waxy kind of looking material, which was by mistake as this amylum word was used, and since then this amyloidosis or the amyloid word has become very popular. So this is just fact. So Neeraj can continue.
Yeah, question 5. So next slide, please. So special stain for the detection of amyloid congruent. Any other stains that you are aware which can be used for some other stains for use for characterization of amyloid? So congruent is the gold standard for sure. Then there are other stains like thioflavin T and Elcian blue being utilized for characterization of the amyloid. So they are not readily done at most places. Congruent is the commonest stain, but there are some other stains available as well. Next slide. So we come to the case 7. Next slide. So this was a 60-year-old female who presented with neuropathy, subcutaneous nodule, and easy bruising. And on serum protein electrophoresis, there was an MBAD. And as opposed to what we have been hearing till now, IgG type of, this was an IgM by immunofixation. And the IgM was 161 milligram per deciliter. Along with it, the WBCs was 6,800 with around 55% lymphocytes and hemoglobin of 7 with an MCV of 83. So it was normocytic normochromic anemia. Platelet count was also slightly low. Next slide. And this is how the peripheral blood looked like. You had plasmacytoid cells in the peripheral blood along with some rouleau formation. Bone marrow aspirate was subsequently done in this particular case, which was very dilute. And this happens sometimes, when it is overpacked marrow, not there are chances that cells may not come out. And this is the aspirate findings. It was 52% lymphocytes with around 4 to 5% plasma cells, and there were occasional lymphoplasmacytic cells in the peripheral blood in the bone marrow. Next slide. Another picture showing the plasma cells, which are slightly abnormal looking. You can say flame type of cells, but not typically, but some flame type of cells. And on the right end, can you go back? And the right side, you have a cell which is seen. Anybody would like to comment on the bone marrow aspirate, the right end? What is this cell?
The mast cell.
This is a mast cell, and very nice. So recognition of the mast cell is very important, and in this particular case, whenever you are suspecting, LPLs or lymphoplasmacytic lymphomas, seeing a mast cells, tells me that I am dealing more with the Waldenstrom's macroglobin with the history, with the history of the hyperviscosity type of syndrome. Then you have IgM being documented, and I am seeing lymphoplasmacytoid cells along with mast cells. It is enough for me to suspect that this is likely to be a lymphoplasmacytic lymphoma. If possible, flow needs to be done in this particular case. It was dilute, so we went back to the characterization of this on the bone marrow biopsy. Next slide. And this is how the biopsy looked like. Anybody would like to comment on this? Any? Dr. Zoya? Anybody? Yeah.
The biopsy shows the bone marrow, which is hypercellular to
Yes.
the edge. Yes, and also there's some areas where it's showing paratrabecular infiltration or paratrabecular feeding spaces.
Next slide. It's hypercellular bone marrow. And next, yeah. So this marrow was absolutely packed, and whenever you see such a marrow, you would like to suspect that this is a lymphoma initially, and based on the history as well. So as I mentioned earlier, you would like to go with the panel of markers with 320 and Ki, and since this had a IgM and we had a suspicion of myeloma as well, so we added a panel where do CD3, 20, and 138, and you could see the CD20 nicely highlighting majority of the small lymphoid cells that we were seeing on the bone marrow biopsy. There were scattered CD3 positive cells, but primarily CD20 positive cells, and there were a lot of 138 also highlighting the plasma cells, though they were less than the CD20 positive cells, somewhere in the range of 10% of the cells were also seen. We try to look at whether these plasma cells are abnormal. They were CD56 was negative. Next slide. So this is an immunohistochemistry based approach. If you have flow cytometry, that is very easy to demonstrate whether these are lymphoid cells or these are plasma cells, and you can look for the expression of these cells. Whenever you are suspecting Waldenstrom, the variation in the intensity of the lymphocytes, plasma cells, and lymphoplasmacytoid cells. So that is very important to document that, or it helps you suspect and you are able to diagnose. So variation in the intensity of CD20 and variation in the intensity of CD138. So there will be cells which are bright 138, and there is a moderate intensity of 138 and dim intensity of 138. So these two stains are very important when you are looking to diagnose a lymphoplasmacytic lymphoma. So here, subsequently, kappa and lambda immunostains were done, and you could see the kappa being predominant. So it was a kappa restricted population, and since this is a small B cell population, you wanted to rule out whether there are other types of lymphomas or mantle CLL or follicular lymphoma, and there is a plasmacytic differentiation. So additional markers like CD5, 10 were done, and they were negative. Next slide. So 5, 10, 23, and cyclin D1 to rule out CLL with plasmacytic differentiation, mantle cell with plasmacytic differentiation, or so. So basically, you were dealing with the lymphoplasmacytic lymphoma based on the infiltrate, which is CD20 positive, CD138 positive, varying intensity was seen. Whenever you are dealing with such a scenario, there are a few differentials that you need to keep into mind and it is one of them is a marginal zone lymphoma with plasmacytic differentiation, and sometimes, as Prashant had mentioned, small cell myeloma. So small cell myeloma is a one entity you always need to keep it in mind and include 138 in your IHC panel. If you are not doing it, you are likely to miss out a small cell myeloma as either um, uh, uh, as a B cell neoplasm, or it could be diagnosed as a mantle cell lymphoma, because these tend to be 20 positive and also cyclin D1 positive. So this panel has to be appropriately done. You have two types of Waldenströms. One is two types of LPLs. One is Waldenstrom, and one is that is IgM, and other is non-IgM. So two types of lymphoplasmacytic lymphoma, and within lymphoplasmacytic lymphoma, or Waldenströms, you have two subtypes. One which is MYD88 positive, and one which is MYD88 negative. So MYD88 L265P somatic mutation is seen in approximately 90% of the cases of Waldenstrom. It helps you confirm your findings, though you already are aware of the immunohistochemical profile and the IgM in this particular cases. But this particular mutation sort of helps you characterize and then diagnose little more confidently, or gives you an objective criteria for diagnosis of this. Next slide. So so not only MYD88, now we also know that this Waldenström has two subtypes, one which is MYD88 mutated and one which is wild type. And within MYD88 mutated, you have a percentage of Waldenströms which are CXCR4 mutated. So around 40% of the Waldenströms will have CXCR4 mutations, and based on this profile of MYD88 and CXCR4, you can now characterize your Waldenströms into three subgroups. Some of them respond to BTK inhibitors in a good way, and some of them are resistance to to resistance to BTK inhibitors. So diagnosing and characterizing them based on the genomics is also becoming important nowadays. Next slide. So WHO 2000, same things have been highlighted, and on flow cytometry, as I mentioned, they have IgM and they are IgM positive. Rarely they can be negative as well, and they typically have CD19, right, CD20, 22, 25 positive, and 10, 23, 103 are negative. There is a proportion of cells which express CD38, and there is MYD88 mutations, as I mentioned, very typically associated with Waldenstrom's macroglobulinemia. There is also description of CXCR mutations in around 40% of the cases. Next slide. There is a revised IPSS score where there are 3 or 4 markers which are taken into account, where age more than 75 seems to be the most important point, where elderly, they do badly. Then you have beta 2 microglobulin, LDH, and serum albumin. Then you can prognosticate your Waldenstrom as per these criteria. Next slide. So we come to the question 6. So Waldenstrom macroglobulinemia is characterized by the following, except. And Dr. Mulenga, would you like to take this question?
Deletion of 17p, which is option B.
Next slide. Yeah. So yes. So as I mentioned, Waldenstrom is MYD88 positive in 90% of the cases. There are CXCR4 mutations in 40% of the cases, and it is a IgM type of M proteins secretion, and deletion 17p is not usually seen. Next slide. So you're right. So role of flow, Prashant, would you like to take up this?
Yeah, so as we have seen that there is 2 components in this disease. One is the lymphocyte, that is abnormal clonal lymphocyte B cells, and we also have plasma cells. So usually when we look at flow cytometry, using flow cytometry, now it has been part of essential criteria as per the WHO 2022. So it has become essential to do immunophenotyping by flow cytometry to confirm the diagnosis, and where you can identify both B cells as well as plasma cells. So you can see here. And usually we see this pattern where we have B cells which are 38 negative and 20 positive, and as they become plasma cells, they gain CD38 because strong CD38 expression is a typical feature of plasma cell, and they lose CD20 because they are differentiating from B cells to plasma cells. So they can show maturation pattern. There is this maturation pattern, and this becomes this. You can see these plasma cells highlighted with dark blue color CD138. They show the clonality, as well as you have typically CD25 dim positive, 19 positive, 20 positive, IgM positive, and 20 positive, 45 positive plasma cells, B cells. So we have B cells, and these plasma cells are typically CD19 positive. You can see the plasma cells are not like myeloma where you lose plasma cell and CD19 as well as CD45. So the plasma cells in LPL are usually 19 positive. They are usually CD45 also positive. In fact, they also can show surface light chain expression sometimes, but cytoplasm based to do cytoplasmic light chain expression. So this pattern is typical feature of lymphoplasmacytic lymphoma. So the one of the important fact, if you look at Waldenstrom macroglobulinemia, was first described by Dr. Jan G. Waldenstrom from Sweden in 1944, and in fact he described only 2 cases. So he published he has just seen 2 cases where the patients had bleeding from the nose and mouth and anemia, and there was hypofibrinogenemia, the swollen lymph nodes, and there's in the plasma cells, neoplasm in the bone marrow, and hyperviscosity, which is called viscosity to the bleeding disorder, and because of hypofibrogenemia was there, and he found that there was hyperviscosity and increased heavy chain proteins, which we call macroglobulins. And because of these 2 case reports, he published these 2 case reports in 1943, and first time he's defined. So even the single case is very important if you see some typical features. So single case report, single or 2 cases can define a new entity, or can confirm a new disease. So this is how the Waldenstrom has defined these cases, and then this entity came into the existence. So just so next case is case 8. We'll finish soon. So this is a case of 41-year patient. We had pain in right hip, and on biopsy there was a lesion swelling in the right hip. So there was biopsy done from the right acidogram shows plasmacytoma. Okay. Baseline bone marrow plasma cells were 6%. Also, the M band was done 1.1 gram per deciliter, and the patient was treated with EBRT, that is radiotherapy. And after 4 months, the patient had persistent increasing pain, bilateral pain. In fact, there was paresthesia in both lower limbs. There was weakness. Now there was lumbosacral flexopathy. Even on neural studies, there was on the alpha S1 motor axonal degeneration. The prolactin levels were high. There was polycythemia with increased RBC counts, but the JAK2 was negative on molecular. So lower numbness in paresthesia, polycythemia. There was edema in soft tissues levels on MRI and CT scan, especially the iliopsoas muscles, gluteal muscles. There were multiple lymph nodes. There were there inguinal and pubic lymph nodes, retroperitoneal lymph nodes were there, and the patient had plasmacytoma. Anybody wants to take a guess? What?
The poem syndrome.
Yeah, so that is a good guess. That patient possibly have a Poem syndrome because of this presentation. And this patient, so what do you want to do investigation in this? So we have done VEGF levels. So VEGF level either done by I think ELISA, as well as they can be done by flow cytometry. So we do by flow cytometry here, and it was increased. You can see the 1346 in plasma. It was done. So this was the case of plasmacytoma with Poem syndrome because of these all features. So if you look at the Poem syndrome, there are multiple criteria as per WHO as well as the earlier criteria. If you look at there are mandatory criteria, that means that should be there. Then there are major criteria and there are a few minor criteria. So total there are 11 criteria. The first two are mandatory, that is polyneuropathy. So the patient has lower limb weakness and paresthesia in lower limbs. Then there was monoclonal plasma cell disorder. So usually, almost always, it's a lambda kind of light chain. So in this patient, there was M protein. Then in major criteria, these are the two mandatory criteria. Then there are major criteria. Only one major criteria is required. So either the patient can have Castleman disease or lymph node, sclerotic bony lesions, or increased or elevated VEGF levels. So when you look at VEGF levels, if you do it from plasma, then the cutoff is 200 picogram per ml. If you're doing by serum, so it is the levels is high because in serum you get the cells get clotted and the platelets get activated because of clotting mechanism, and platelet is also source of VEGF, so you can have high levels of VEGF there. Okay, so those are three major criteria. One of the major criteria should be there. And if you look at the minor criteria, which include organomegaly like splenomegaly, lymphadenopathy, and hepatomegaly. This patient had lymphadenopathy. Then extravascular volume overload. That is so look at Poem in P is for polyneuropathy. Then M is for monoclonal plasma cell proliferation or disorder. Okay, O is organomegaly. So O is organomegaly. Then E for extravascular volume overload or endocrinopathy. And then you have M, that is monoclonal gammopathy, and S for skin changes. So the patients usually like hyperpigmentation, hemangiomas, nail whitening of the nails, or rubor is common. Then also you can have papilledema, thrombocytosis, or polycythemia. So in this patient there was polycythemia, right? So this patient had major mandatory criteria, that is monoclonal protein as well as polyneuropathy. The patient has major criteria like VEGF levels, increased VEGF level. Then minor criteria were like organomegaly, lymphadenopathy was there, edema was there, so and skin and polycythemia was there. So three minor criteria were also there. So this was the diagnosis. This was Poem syndrome. Then we also had two more syndrome. These are rare. At least I have not seen these syndromes. So there is a Tempe syndrome where we have telangiectasia, elevated erythropoietin as well as erythrocytosis, monoclonal gammopathy, perinephric fluid collection, and intrapulmonary shunting is there, and then the new symptom which is added to 2022 classification WHO is SOP, which include adenopathy and extensive skin patch overlying plasmacytoma. So this is new syndrome. Okay, so with this, I think we come to end of this today's session. I would like to thank Neeraj as well as the other doctors who has contributed. Dr. Kanjal Kajus from our biochemistry department, our DM student who now he is ex-DM student. He has passed his DM as DM students. Then my ex-fellow who has helped me to collect all these images, Dr. Anumeha, and of course our adult hematolymphoma DMB who is being treating and collecting these cases. And this is our recent holy picture from one of the beach close to our Mumbai. Thank you very much. I think I would like to request Priti to go ahead with the rest formalities.
Yes, sir. So thank you so much for these very interesting cases. So we'll take the questions now. Bonita, you can start with the question.
Yes, ma'am. We have few questions. One is how to define clonality of plasma cell on bone marrow aspiration.
Yeah, so it can be done by two methods. One is by immunophenotyping, which is easiest and more objective. The other one is by IHC. So IHC sometimes can be difficult. So the people do IHC when doing in situ hybridization also. So that is more effective. But you can do either by IHC or by immunophenotyping by flow cytometry on aspirate.
IHC is very difficult to be done and usually it does not work. There are separate protocols to be able to pick up if you want to use IHC on bone marrow biopsy or lymph node. There is another method called in situ hybridization, ISH method, and that is kind of more reliable in picking up on tissue sections. As Prashant mentioned, flow, if you're able to demonstrate is very good, but in tissue sections, IHC and ISH is, some methods which can be done. But they are slightly expensive side.
Thank you, sir. What is the difference between lytic and sclerotic lesion?
Well, this is where when you have bone marrow, means if there is absorption of bone marrow, when you get this one, so then you see the lytic lesion on X-rays or on scans, CT scan. The sclerosis, if it is also replaced by fibrosis, sclerosing basically by deposition of other connective tissue, do usually sclerotic lesion. That's my understanding. Neeraj,
I think same only. Yeah. Specific.
How to enumerate the plasma cells accurately on CD138?
Yeah.
So please go ahead, Neeraj.
Yeah, so you can use bone marrow biopsy, for characterization of this. So usually CD138 is used to be able to pick up or highlight those plasma cells, and based on the number of plasma cells of the total cells, you can give an approximate percentage. But if you're looking at counting it, one by one, then it is not going to be true. It is an approximate idea that you get of the cellularity through that. So you won't get an accurate figure. So it is an approximation.
Usually it is supported by, if you have biopsy and if you look at aspirate together, and if you, on aspirate you do the differential count and biopsy you correlate with that, with experience you'll know when you call more than 10% or less than 10%. But you have to remember, although the 10% is criteria, you can have sometimes 11%, which can be the same disease like 9%. So it is just matter of one. But you have to understand, if you see sheets and clusters of plasma cell, of course they are going to be more than 10%, which is more favoring the aggressive disease than disease which is indolent disease kind of MGUS. So to be honest, you cannot accurately count, but you have to correlate with bone marrow aspirate and biopsy both together. And by frequent counting and correlating with biopsy, with experience, you know when to call it is more than 10% and less than 10%. But if you want to go by count, I think it is aspirate where you can do the counts, if it is representative, provided that these are representative aspects.
The question is, in plasma cell leukemia, do we do flow cytometry on peripheral blood sample?
Yeah, yes.
What is the difference between non-secretory multiple myeloma and light chain myeloma?
Same. Non-secretory myeloma, if you have, instead of heavy chain, if you only light chain, then you can call light chain myeloma. Instead of, see, it's non-secretory means it will not secrete heavy or light chain both. Right? So non-secretory myeloma is the one there is no secretion only. Now, and in secretory myeloma, you can heavy chain. So usually this you have heavy chain and light chain both. But in only light chain myeloma, there are no heavy chain. Only light chains are secreted. So that's light chain myeloma. But it is still secretory myeloma. Non-secretory, there will be the absence of both heavy and light chain. Now there is something called the non-producing myeloma also. So which can be identified by flow only, because where we can identify that light chains are there, but inside the cells only. These are not secreted, so they are produced, but they are accumulated in the plasma cells. So by flow cytometry, by doing cytoplasmic staining, intracellular staining, you can identify and you can confirm the light chain there. But in non-producing, even the by flow cytometry, you won't see any kappa and lambda, so they both will be negative. So those are non-producing, they're very rare. I've seen only 2 cases till now in last 10 years.
Next is how to differentiate Waldenstrom from IgM myeloma.
Yeah. So that is two different things. Myeloma is if there is a myeloma, you need to work it up or diagnose myeloma as per the CRAB criteria or whatever the conditions that we have seen. See the various markers are there, but they instead of IgG, it will have IgM. But on the flow or IHC, it is all plasma cells that we see. But here, in cases of Waldenstrom, it is a lymphoproliferative or the lymphoplasmacytic lymphoma. So it is a lymphoma with a plasmacytic differentiation, predominantly CD20 positive, and that is what has got IgM associated with. So two different things. IgM myeloma being very, very rare. I would have seen only 1 or 2 cases to the tune that I never used to believe that there is an IgM myeloma existing. But I recently saw an IgM myeloma, and now I have started believing, okay, there is an IgM myeloma, where everything is myeloma, whatever we see, but instead of IgG, there is an IgM meaning. So that is what. You want to add anything, Prasad?
No, that's right. So it's lymphoma, lymphoplasmatic lymphoma is lymphoma, and it's myeloma. Only thing is the heavy chain is different.
I can just see 2 more quick questions, sir. What is the normal kappa to lambda ratio in flow cytometry for plasma cells?
So see, by flow cytometry, usually if you look at traditional articles or papers, it says 3:1, but we don't believe that, because usually it is can have some derangement between this, even polyclonal plasmacytosis. So we usually take 9:1 as the ratio. So if you identify plasma cells, because now we have multicolor flow cytometry where you can do 6 or 8 or more than 8 color flow cytometry, meaning that we can put multiple markers along with kappa and lambda. So we can identify abnormal plasma cell by using like CD56 expression, loss of CD19, or loss of CD27 or 81. And then if you identify those plasma cells and then look at light chain, usually you get even more than 95 or 94:1 kind of ratio, or 94, 20 or 30 kind of. So usually we take more than 9:1 as a ratio to define clonality, because usually see with this proper gating, you always you will have more than 90% abnormal clonal plasma cells out of total plasma cells, total gated plasma cells.
Okay, I think so remaining we have covered in all, during our presentation, all the questions. I would like to request Dr. Naveen sir to give his comments here.
Unfortunately, Dr. Naveen called and he had to leave in between. So
Okay.
he's not there.
Okay, so here I would just take this opportunity to thank our speakers again for such interesting cases. And the historical facts given by Dr. Prashant were cherry on top. So we really enjoyed it. It covered the entire spectrum. So we are really, really thankful for that. Just please bear with me for 2 more minutes. I have some announcements to make. So our next talk is MRD in acute leukemia, again by Dr. Prashant Timbhare. It's on 14th of March at 7 p.m. So kindly do join us for the same. This is a QR code. You can scan this and you can join our Telegram group for all the updates for the upcoming talks. Thank you so much, everyone. And